Hello, I'm Adam Blum. I'm CTO of HealthKey. In 2024, I was diagnosed with follicular lymphoma. I found a lot of frustration in trying to find matching clinical trials. Tried all the commercial clinical trial matchers, of course, tried the underlying registries, including EUCTR here in Europe, and then built something called CancerBot, which has since been acquired by HealthKey Incorporated, who is building various open source components to help people build better trial matchers and other better personal health record products. So, with that, let's talk about trial matching. Trial matching today doesn't actually match trials as done by the underlying registries, by commercial trial matchers, of which tried more than a dozen, and by open source products. I'm going to talk a little bit more about the open source matchers, such as Trial Match AI, Trial GPT, OncoLLM, match on vignettes. So for me, it would say healthy man, follicular lymphoma, stage 1, bulky inguinal lymph node tumor. And then, of course, they don't actually match on eligible. They just say, okay, the matcher has a ranking, and if the Dr. Gold Standard is in the top 5, then it works. And of course, that's not true eligibility. The other thing it does not do is rate suitability or goodness for the patient. The cost of getting this wrong, when I discuss this in the US, I say 3%. In Europe, the numbers vary wildly, but the average is probably about the same. It's not that they don't qualify. It's just very difficult to parse the matches from the unstructured text. So let's talk about some ways to make this better. So we've boiled it down to these 5 principles that we call begin. So the B is for bot-based onboarding, E is eligibility focus, G is goodness for the patient, I is interoperability within the larger system, and then N is oriented towards the patient navigator. Okay, so bot-based onboarding, we want to do as much as we can to complete the record, and bots can really help with that. So you start with the structured intake, you pull FHIR records, PDFs, whatever it is that you have. And then as you get close to the trial, we can bring up the trial then and see the gaps against the trial, and then have a bot-based dialogue with the patient and say, okay, what is this missing at? What is your serum bilirubin level? What is your ANC level? And that they can either find it, or they can go and get ideally a very small set of additional tests, and the bot can drive that. So the most important thing, of course, is be eligibility focused. The hard part is getting the structure out of the unstructured text. And so we have this process that we use. If you just give a patient and a trial to an LLM and say, do they match? It's incredibly inaccurate. It's below 70%, not useful. So we do this per attribute extraction of the trials to create truly structured trial databases. So we actually have 533 prompts that we use for follicular lymphoma. We actually ask those 533 prompts against every single one of the more than 1,500 active follicular lymphoma trials. The result, as presented at last year's ASH, was 85% F1, which is the harmonic mean of precision and recall. Precision, did you get the attribute correctly that you extracted? And then recall, of the attributes that are there, which ones did you get? Obviously compared against hand labeling with a subject matter expert. At BSH 2026, we published our results with multiple myeloma, and the result was 89.9% F1. And recent tests with other diseases, we've added CLL, MCL are above 90% F1. We'll be having papers out shortly that demonstrate that. So goodness for the patient. So once you've determined eligibility, you can now look at goodness or suitability. We talked about this doctor labeled gold standard, which is an opaque mixture of opaque and mushy mixture of eligibility and goodness and for the patient and and a lot of doctor judgment. We're not trying to do this approach. You're eligible or you're not. Now that you're eligible, what is good for the patient based upon the patient's preferences? What are those preferences? The factors are risk, benefit, burden, and distance. We created our own rubrics for risk and distance, so that we did consult with Harvard Department of Clinical Informatics on defining the risk rubric. The benefit is actually, even in the US, we use ESMO MCBS. It's a very nice benefit rubric. The burden is from some research from Gatz et al. We have an article on the CancerBot site. If you click on the score, it'll break this all down mathematically for you. Okay, so you can see that we have two patients, and they're both going to get different scores for the trial based upon their preferences. Okay, so another principle is we've made this all open source. If you're going to make it open source, you want people to integrate it into their systems. We have multiple people using the underlying exact trial matcher, and it sits on top of our extensions to OMOP to allow it to be interoperable with other systems. So what are we really talking about with OMOP? It turns out if you do trial matching against OMOP, it's quite slow because it's highly normalized. So we have another project called CT-OMOP that takes OMOP as the stuff that's missing for doing trial matching, and we add a flattened denormalized projection, which makes it really great for trial matching. But this is also quite useful for doing things like building predictive models with machine learning. And the final principle is N is for navigator oriented. Involve the navigator in the process. Navigators are great for really double checking informed consent, helping the patients understand maybe things that they don't understand. So embrace the navigator at the foundation, patient support organization, large hospital, whatever. Make your matcher work with navigators. Okay, so these are the 5 principles. We hope you follow them. Just as an example of these principles, HealthKey has a suite of components called FRAME, Patient Health Record Architecture for Modular Extensions. And the 2 that are most important here are CT-OMOP that we've described. It's all available open source. And then EXACT, which is the open source matcher that also follows these principles. But we'd love to have you use our open source. It's all out there for free. If you do not, you can go to HealthKey AI and click on the open source tab. Whether or not you do that, we want you to, whether you're building or evaluating or buying one, ask about these principles. Okay, thanks very much.